Welcome to the Executive Innovation Show podcast, where we bring you real executive conversations with industry game changers and thought leaders. We ask the questions you're thinking, what you're scared to ask, and we make your brain hurt afterward. With your host, Carrie Chitsey, co-founder and CEO of One Touch Video Chat, live video interviews, and the nonprofit Humans Helping Humans.
Hello, everybody, and welcome to today's podcast. We have a great podcast for you. We're going to be talking about primary care, direct care, proactive care, or is it just good patient care? Brought to you by One Touch Telehealth. I have two awesome guests with us today. First, we have on the show Dr. Brian Bluth, who is trained and board certified in family medicine. He's got a private practice in rural Oklahoma. We won't count the Sooners against you. And he's gained a lot of interest in rural family medicine in his residency in Des Moines, Iowa. He loves the aspect of full spectrum medicine in rural setting for outpatient care, inpatient care, ER, OB, pediatrics, geriatrics, including being a nursing home director as well and doing laparoscopic surgeries. Later in the show, we're going to be talking to Dr. Ben Barlow, who's the Chief Medical Officer of American Family Care, which operates 210 clinics in 26 states and sees 3 million patients per year. He's board certified in emergency medicine and joined AFC after 14 years in the Air Force, and he ended his military tour at the White House serving President Obama and President Trump's medical team. So first on the show, Dr. Bluth, how are you today?
Good, thank you.
Well, cool. We're going to talk about some rural health, and really, we've seen a lot of changes in rural health with practice groups and physicians really looking to kind of deeper that patient-physician relationship, moving out of that fee-for-service model and really more transactional, moving to that wellness model. Do you see this as direct care, patient care, wellness care, just good patient care? How do you think about that?
Oh, I would say it's all of those things. I've discussed this with other professionals, and I just feel like at this point, we should have never let insurance get involved in the primary care service, because I think it muddies the water. There needs to be more direct patient and doctor relationship, and you add that third party in there and it's unnecessary. There's extra services that might be added on because of one reason or another, increasing the billing or whatever. And I've just talked with some guys who really have this figured out, and I'm very interested in molding my practice to that sort of a model where I'm directly engaging people, helping them save money and lower their premiums. Insurance really is just for those big major expenses, and primary care can be very inexpensive for patients. And maybe we need to have that concept in this country of lowering your premiums, having a higher deductible, and directly engaging the physician through some kind of direct payment model rather than a third-party payer.
Yeah, and I think with a lot of the higher deductibles, it's kind of pushing in that direction, right? As health insurance has gone up crazily. Yeah. Nobody can afford that zero deductible, even 500 or 1,000 anymore because the rates are so crazy, right?
Correct. Yeah.
So I want to talk a little bit. You've, got your practice and you're kind of plugging in some specialties, some clinics, some nursing homes, you're got your hands in a bunch of different things. And we always talk on the show about, physician experience, and better physician experience leads to better patient experience. As you look at, expanding a practice in a rural community, and you're being pulled in kind of all these directions to help out other facilities or, make it more convenient for your patient to pull in specialty and so forth. How do you see the future of that primary care now that there's so many technologies that still allow you to have that face-to-face with the patient, but there's telehealth, there's remote monitoring, there's, online scheduling, there's waitlisting, there's all these things that patients are demanding, but also that can help with the physician experience. Where do you see that technology in that world playing in, for your group?
Well, I've kind of, right now in our country, there's a problem with these rural hospitals. There's, the revenue isn't there. The Affordable Care Act has helped out some places, other places have struggled, especially in Oklahoma, where they haven't adopted the rules of the Affordable Care Act. And it has really caused a lot of struggles. There's hospitals closing down in these rural areas. And really, the primary care physician is on the front line of rescuing these places. And I feel like that's our job and our duty to bolster up these communities and these hospitals in these smaller areas and figure out how we can take over to help out their revenue, and also bring in specialties where they obviously get better reimbursement for the types of things that those people bring in. And so that's what a lot of us have tried to do. I'm not the only one, but I've been able to work hard at getting that done in our community. Built a new facility here with the idea that we would bring in specialists to our area to help support our community and our hospital. It makes it more convenient for the patient. They don't have to travel. We're about an hour away from Oklahoma City, the nearest large city. And most physicians, most specialists congregate in those large cities.
Right.
So to get them out here, there's the physical aspect, so patients can see them, they can engage them, they can do procedures here. They don't have to travel and go through that hardship of having to go a distance to get the things that they need medically. But then to your point about the telehealth, we're also developing that, and it's really helped us engage the patient to come into the clinic and to the facility and directly contact a specialist that they otherwise wouldn't be able to get to see. Our endocrinology group is on the front line engaging patients, and I actually have people traveling an hour further northwest to come to my building so that they can communicate with a specialist in the city through the telehealth method. And so we've got some cardiologists and oncologists and what else? The pulmonologists are involved in it, and orthopedics now. And that really supports the hospital, and it really helps the patient out.
Yeah, so that's great. So you've got folks that are, driving to your facility to then, connect farther from telehealth, because obviously it's back to patient convenience and they still want that face-to-face. Now that telehealth, with the technology and it being, more affordable and the new billable codes coming and so forth, how do you see that changing as it's able to extend to the home? I've experienced, especially with a nursing home right now, really a great engagement and great success. Now that Medicare has opened up, that if a patient is in that skilled nursing facility, that they can contact me through telemedicine, and I don't have to ask them to bring this patient who is immobile and it's difficult to get them out of the home to my clinic. I can really see their, just yesterday, hey, so-and-so his hand's hurting more. There's some swelling going on, maybe some redness. Hey, let me take a look at it. I'm not just going to guess, oh, wow, that could be gout or it could be cellulitis. I don't know. Let me take a look at it. Let's see his vitals. And the nurses love it. They engage in it. They just get on their phone. They can connect with me through telemedicine, and the facility, once they figure it out, can bill for a facility fee, right? Yeah.
And I get to bill a Medicare for that visit as though it's an office visit. So I think it's a great service. We get reimbursed for something that normally maybe would be taken care of with a phone call, but I don't get the ability to really diagnose and figure things out.
Yeah, I think that's critical. I mean, we're seeing so much on the long-term care, and when Medicare unleashes it, and it doesn't have to be, a site, then you can even service some of these nursing homes that don't have a physician. Maybe it does rotations, or maybe they have an agreement with some practice that, they can call them or whatever. Maybe they swing by once a week, but nothing ever tends to happen in medicine at that, 2-hour window that the physician comes by, right? It's always at night, or it's always when
Right.
next care, right? And
Right.
so that allows you to be able to do that bedside from that standpoint. So a couple other things I want to talk about is as you've been using telehealth, are you seeing you talked about just a minute ago, the nurses, engaging in it. Are you seeing anything like generation wise that, a lot of times there's a report just out, hey, don't count seniors out. They want telemedicine too, especially for specialty. You're in rural areas. We get a lot of times like, well, hey, rural demographics, they don't know technology as well. And I'm always like, I don't know that we should be casting like entire geographies from that standpoint. What are you seeing since you are in that rural demographic? Are you seeing any stereotypes that we should be throwing out, or generations using, not using?
I think there's a couple ways to answer that question, because number one, we actually in our whole hospital here, we have utilized a telehospitalist service, and it was very glitchy. It didn't work all the time. He couldn't get logged on. Things wouldn't, and it would take too long. And so then people get biased against it. There was another facility where they didn't like the physician who was on the screen. The doc in the box just wasn't a good bedside manner. And so then they get these biases against it. And then someone like me comes along and suggests, hey, this can be a cool way. You guys can capture more patients. You don't have to send them to the city because you've got someone like me experienced in taking care of them in the hospital, and you can keep them there. You can keep that revenue, but I can't be there. I can't travel there every day. But with the camera, it's like I am there. And if you just get used to it, get over any bad experiences you've had in the past, and help the community understand, once they engage with me, I think they'll know that this is a way that they can really enjoy that concept and capture that revenue, keep that patient there. And on the other side, I still don't think people have recognized the value of it right now in the flu season. I can engage with people. They don't have to come into the lobby and sit down with other sick people. Right?
Yes.
And I think the word just needs to get out there. People need to get used to it, understand that there's a cash pay way of it, or there's even insurance can be built for it. And we even have a drive-through. We'll do your flu and strep swab through the drive-through. Don't have to come in. Just get on the video screen,
This is everybody's public service announcement. If you have the flu, please use telehealth.
Use telehealth.
Everybody else. I had for the first time last year, like full-blown flu. And I literally, it had me down for like a solid 7 days. I think it was the only time usually when I'm like sick, like, cause I'm a workaholic, usually when I'm sick, like I'll just muscle through it.
Yeah, me too.
I was literally, I don't think I woke up for like 48 hours. I was like dying. So please, everybody, use telehealth for the flu season.
And get your flu shot.
And get your flu shot. If you could start doing flu shots via telehealth, I'm in.
Yeah. Well, through the drive-through, we'll shoot in your arm and in your car.
I might even drive to Oklahoma for that. It'd probably be from Texas. It would probably be less than me sitting in a doctor's office for 2 hours for a 20-second shot.
Right.
Well, cool. So one last question I have for you. Do you, when you're serving patients, do you act different on video than you do if I was sitting in front of you?
I don't, but I have noticed that the patient does. So often, my female patients, they'll have the screen kind of to the side. Like they don't want me to see their whole face. Like,
they don't have on their full makeup.
Yeah, I don't know. They want to get it over with as fast as they can. And, but that's actually nice because we get right to the point. We get taken care of what needs to get taken care of. Yeah. And they're happy getting what they need. And we go. And it's something that you can fit in through the day that way.
Right. So the national average is that a physician, in rooms spends about 5 to 7 minutes with patients. Do you see you spend about the same time on telehealth or different?
No, much less. Most of my telehealth right now has been with our local university. We have a 4-year university in our town and a state college. And we've negotiated a deal with their sick clinic, their health clinic, where if they need they just have a nurse staffing it. So if they need a prescription of some sort, they need a connect with one of the local physicians. And they've been sending the kids to 1 or 2 different offices that have engaged with them before. Well, now with the telehealth that I've offered them, they just send them into the next room. They connect on a video screen with me, and I jump on there. And I mean, it can take 60 seconds. I just say, okay, you tested positive for strep. Are you allergic to any medicines? Been sick for how long? I do a quick little note. Okay, and literally my favorite is in there, amoxicillin to the pharmacy. You're done, and it's so simple, and I can squeeze that in between, any visit all day long.
Ah, that's awesome.
Mm-hmm.
So we always ask before we close the show with each guest, what are 2 things as being in healthcare as a physician that kind of keep you up at night outside of family, kids, all that fun stuff that keeps us all up?
Well, funny enough, nothing kept me up at night before I endeavored in this new building project I put together. And now, it's like, what's really funny is what we're talking about as the innovation. I've always had this mindset of innovation and connecting patients better, getting them what they need more. And the innovation is turning towards more virtual. And here I've got this physical building that's super expensive. And I'm like, okay, I got to keep bringing these specialists out. How can I convince them? How can I keep them coming so that they're interested, engaged with the patients, and convince them that this telehealth thing is really useful and will be productive for them and to help out the patients. And so that's something that's kept me up over the last year, just engaging that and trying to make sure that continues and that happens. And then just educating the public, because I think telemedicine is so useful and so innovative, and not everybody recognizes its usefulness. And I'm excited to try to keep that word of mouth going and engaging them and get the word out.
Yeah, no, that's awesome. And just the comment on that last one, I know we've talked about this before, is that it's the fear of the unknown, right? And it's like, I think the number is like, once you've done like a telehealth visit as a patient, then you're like super comfortable to keep doing it. But it's like that first one, you don't really know. Like,
that's exactly right.
All the time, it's like, I didn't really know if it was like a live doctor on the, like, they don't know, like, is there really going to be a human on the other end? And then I think from the physician standpoint, I always joke, it's like the younger physicians are always like, hey, we have to do this. Like, I need better work-life balance. Like, there's no way I can see more patients if I don't do it.
Right.
And then the older physicians are always like, no, I don't believe in that. And then all of a sudden we got a call like a few weeks later. It's like, hey, Dr. Jones heard on lunch that Dr. Smith was seeing all these patients and now he wants to do it. I was like, oh, the one that was like totally against it. But now that somebody else is like making more money or seeing more patients, all of a sudden, it's like that barriers come down,
Yeah.
I always find it so interesting. We stereotype patients, we stereotype physicians, like all over. Well, Dr. Bluth, it's been a pleasure. We're going to swap over to Dr. Barlow, but I want to thank you so much for being on the show. It's been great to have you.
Likewise. Thank you very much.
Great. Dr. Barlow, welcome to the show.
Thank you. Great to be with you.
Well, awesome. We were talking earlier about, primary care, direct care, kind of this new active patient care, patient-centered care. And American Family Care started back in 1982 before we had all these retail clinics kind of on every corner. And I'm sure you guys' model has changed kind of dramatically over the years now that you guys have 200 plus locations, 26 states. How is that model? And I know you came on board not too long ago, but you've been there a while. How has that shifted in your mind? Are you guys more accessible care, primary care? Tell me a little bit about kind of how that's transitioned for you guys and where that focus is today.
Sure. So when we started in 1982, Dr. Irwin, who started the company as One Clinic here in Birmingham, always had that vision of accessible primary care. He didn't pick urgent care. That's not what he labeled himself. He was a family practice doc. And so he always visioned us as accessible primary care because he saw that need in Birmingham. Yep. And so from that beginning, we have done that typical urgent care, which you think of as typical urgent care practice, which is lacerations, colds, flus, but also because of the need of the community, we've also paid attention to things like hypertension or monitoring a patient's diabetes and wanting them to follow back up with us. If we put in those sutures, we want to take them back out because we want to see how that laceration did, if there's anything that the patient needs on that checkup, and to take the sutures back out. We've evolved because of technology. So our basis and our mission is still the same, but we're now leveraging technology to do that better as we go forward.
I know that makes a lot of sense. And, you know, as we have this rural shortage and in a lot of areas, you know, there's shortage on specialty, there's shortage on primary care, there's shortage on even, you know, community hospitals and so forth. Do you think clinics and accessible care organizations, or, you know, however we want to call it, urgent cares, whatever terminology you want to have,
right,
how do you see that in helping, you know, just patient-centered care in some demographics? And I'm sure you guys are looking at that as you're opening new locations, and you said you're leveraging technology, so maybe they can now have a farther reach than maybe they haven't with things like telehealth or remote monitoring. But where do you see the clinics playing that role in, you know, chronic care as we have boomers aging, as we have rural demographics? Where do you think that spot is kind of in the future for that model?
Yeah, a lot of this in our different areas, as you said, we have 214 plus clinics and continue to grow. It's really determined by the needs of that community. And so as we look at our different communities and the different needs, we partner with hospitals or primary cares in the neighborhood, and we kind of see what the needs are of the community. And then we really see what our patients drive us to, because in one area, there may be a heavy need for typical primary care services. In another area, they may not be. There may be just using us as a touch point. So we kind of think of us also as an entry into that massive medical system, to where we can identify these patients, be a touch point for them, and then refer them appropriately across the specialist range that we do so well in the United States. So it's really patient driven. It's driven by what they need in that community. And that's what I'm talking about, leveraging technology too, because with different electronic medical record systems, and we're in the process of switching right now, all this data that patients give us, we can better analyze and help them improve their care with the data that we're collecting on every single patient visit.
Yeah, that makes total sense. And one of the things you said earlier, you know, there's a lot of talk, obviously, in the industry and a lot of great data that millennials are using clinics and telehealth more than, you know, a lot of demographics, because they don't have primary care, or they don't even see value in having primary care. A lot of that's driven by just age, and they haven't run into a lot of medical issues. A lot of that's driven by convenience and, you know, wanting an appointment in an hour and being able to walk in somewhere. What are you guys seeing in this demographic? Are you seeing anything? And as you talk about technology, is that kind of in mind, that demographic, as they get older, have children, things like that? Or where do you see that demographic and what you guys are seeing?
Yeah, absolutely. That is one of the areas that we are directly focusing right now in kind of AFC. You know, I'm a millennial myself, but so I can identify with what we're looking at, right? And so a lot of our patients don't know what they need. And so when they come to us, we have that high 20s or low 30s patients that's coming in for their typical urgent care needs. We are then looking at the things that they should be doing that they don't know. So that obese patient, the counseling on obesity, or drawing an A1C and screening them for diabetes, or following up on their blood pressure when it's elevated, or when some of the older, you know, past that millennial generation in the 50s and 60s, when patients may not know you need a colonoscopy, you need a pap smear, you need mammogram, right? You need all these things that patients may not know. And so we want to catch all these patients, educate them, and refer them to the right place if we can't handle it. And as I said, being that touch point of education for the patient, and then referring them to the appropriate place or taking care of them.
Yeah, and we've heard from a lot of clinics that because 46% of millennials don't have primary care, it gives rather than when they leave the clinic, maybe they did come in for a cold or flu or it's allergy season or whatever. Historically it's been, hey, follow up with your primary care doctor in 7 days or 10 days or 5 days, whatever it is, right? Now that you have this large demographic that doesn't have primary care, it also is an opportunity for that clinic to then establish a relationship to say, okay, you don't have a primary care. Let's see you back in 7 days, or let's see you through telehealth in 7 days or whatever. How do you think about, because historically it's been more transaction, right? And now we're talking about going to really like a wellness and establishing a relationship. How do you think about that when kind of moving to this new model of patients want that convenience, but they don't necessarily, have a primary care doc? Does that make you think differently on those follow-up appointments, those referrals out, if you can handle it?
Yeah, absolutely. So we don't want to take people's primary care patients. So that's one of the things we do is we identify if there's a need with that patient. Do you have a primary care? If you don't, do you want to use us as your primary care? And then scheduling those follow-ups. So we'll identify that at the visit through different prompts in our EMR or the provider who sees that. And then we can tell the patient, direct them toward those times of days that are typically lower volume, right? And so you say, come back at this specific day or this specific window, and we'll see you. We also will schedule those if the patients want those. But as you said, kind of millennial generation, that's not what they want, right? They want to walk back in. And so us, it's say, hey, we want to see, you don't have a primary care doctor. You need to be screened for diabetes. We need to follow up on this blood pressure. Come back into us whenever you want. Or why don't you come back and on Wednesday at noon or something like that, walk back in and we'll take care of you. And so those are the conversations that we're starting to have with these unattached patients that need this care.
Yeah, I like the word unattached patients because that truly is what it is, right?
Right.
So you talked about that. So, blending. So you have all these physical locations, right? And then you have all these patients that are now, we're in this kind of virtual digital world. We can tap a button, pretty much get groceries, food, retail, everything delivered from that standpoint. And we're talking about a demographic that, that is how they live, right? So how do you think about the future of blending the physical location to the virtual world when it comes to retail clinic? So for that millennial patient, you just said that, may not want to come back in Wednesday at noon, maybe they want to do a telehealth follow-up at 7:00 at night, or maybe they want to use online scheduling, when they get back to work and, they want to pick their own appointment. They don't want to have to physically call and talk to somebody because that seems so old school, right?
Right.
So how are you using, whether it's today or in the future, you talked about your technology driven on growth. How do you see that physical and virtual kind of worlds blending from that perspective?
I think in our roadmap and what we're looking at is starting out with those follow-up visits where that may not necessarily need a physical touch by the physician or provider. And so those are things to where we can capture from our EMR or with different third-party vendors what their blood sugars are running or how active they've been or what their blood pressure has been. And these are things that can be easily handled on a telemedicine visit. And so we're looking at doing that possibly in the future for those follow-up visits.
Low acuity.
And because our EMR is going to connect with a patient portal, everything that we have and everything that we do, the patient can log into their portal and they can see all those types of things. So everything is sitting in front of the patient in terms of what they need and suggestions for their care too. So all that can kind of interconnect as we go forward.
Yeah, no, that makes sense. So the topic of the podcast, I want to loop back for a minute was, is it primary care? Is it direct care? Is it proactive care? Or is it just good patient care? What do you call it, or how do you think about it?
We think about it as accessible primary care, and that is good care for our patients because they not only can come to us for those typical urgent care visits, but we want to see you and help you with everything in your life in terms of your primary care needs going forward and identifying those health issues that you may not know you have. And let's catch them early, and let's quit dealing with diabetes after you've had the complications. Let's catch them early. Let's start you on cholesterol medications so that you don't have that heart attack down the life. My docs, my primary care doctors who are catching cholesterol, they're catching high blood pressure, they're going to save more lives and they're going to improve everyone's quality of life than even our specialists who down the road have to fix all the problems. If we can start catching all this stuff earlier, we're going to make a huge difference across our society.
No, that's great. And so one of the other topics that comes up a lot is really around, the large, we hadn't even, scratched the surface of what we're going to see with boomers aging at home, given, it's super expensive to, go into skilled nursing or long-term care. A lot of people haven't saved for that. In addition to people just want to be at home. But that, bears a big question of, historically we, obviously we have a lot of home health companies and things like that nurses will go into home. But this has really put it in the physician's hands to say, okay, if they truly want to stay at home, how do we then extend into home without physicians literally driving house to house, which obviously remote monitoring, telehealth, a lot of those things now are way more affordable and the ability to do that. Is there a role for, someone like American Family Care? Are you guys thinking about the home space? And you don't have to tell me any secrets here, but clinics in general or accessible primary care. I think that there's a big opportunity to be able to extend that in home. And then if I needed blood work or I needed x-rays or whatever, I can go to a local, facility versus having to be in the ER or, driving up those healthcare costs. What do you think about that whole ecosystem and the role that someone like an AFC kind of plays in that circle? Is that completely outside? Is that, integrated in for good patient care? Or how do you see that?
I think with today's technology, the sky's going to be the limit in how we improve our system and how we connect with patients better and how we, do this going forward. I think the first step is always, can we provide the quality of care through these types of advances that we want to provide?
Right.
So as we figure that out, I think as I said, the sky's the limit for a system like ours that is in 28 states. We are interconnected across the country. So you see, as we convert over to our new electronic medical record, if a clinic in Birmingham, Alabama sees the patient and that patient flies to California and goes to an AFC, I have those same exact records. We are connected. And so you can think about that in terms of, as you're talking about telehealth and you're talking about at-home monitoring. I mean, the whole nation has just been connected by, having this healthcare delivery system that is in 28 states and pushing and probably in 50 someday. And so for us, that's exciting and absolutely everything's on the realm of possibilities for us.
It sounds like it. You guys are growing like crazy. So you're doing something right.
Yeah.
So I heard somebody say the other day, it was kind of funny in relation to healthcare, as people, are trying to silo, different healthcare of, outpatient and hospital and clinic and telehealth, like it's different silos. And instead, we should be thinking about a patient across, the journey in which they want to interact. And the comment was, when we first started buying things online, everybody threw around as, hey, we have to do e-commerce, right? We have to have this online store and we have to do e-commerce. It's like, when you say that you bought something online, do you say that you bought something or you went shopping, or do you say, hey, I bought something using e-commerce? It's like, nobody says that anymore. Right. And so it's like, well, at some point you're going to say, hey, I saw my doctor. You're not going to say, hey, I saw my doctor in an outpatient facility, or I saw my doctor at telehealth, or saw my doctor in a clinic. It's just, hey, I saw, I have a doctor's appointment. Right.
Absolutely. And
it was pretty interesting. It's like, as much as I buy on Amazon, it's like a package every day. It's not like, hey, I'm using e-commerce this afternoon. It's like, hey, I bought a water filter,
Right. Absolutely.
Saved me 2 hours from having to go to the store to do it, so it was kind of interesting, parallel from that standpoint. So as we wrap up, we always ask, what are two things that as a healthcare executive that's really keeping you up at night, taking out family, wife, kids, all that fun stuff related to healthcare? What are two things that are kind of front of mind for you?
It is how we continue to evolve this process of connecting patients with everyone across the healthcare system. And so as we have patients come in, I want to make sure that they're getting the quality care, but also getting the follow-up care and then getting referred to the right specialist. And when they have problems, that whole ecosystem of the healthcare system knows what's going on and can take care of the patient the best way. And so the medical community historically has lagged a little bit behind in terms of technology. And for me, it's keeping up because our patients are expecting us to keep up. And so it's not only making sure that we're delivering quality healthcare like we always have historically, but then implementing this new technology and doing it the right way so that the quality stays there in terms of what our patients expect. And so that can sometimes be difficult as new technologies are, ingrained into what we do as a society. You have to keep the quality there behind it. So if I'm purchasing something from Amazon, I don't want it to arrive in the mail and be junk, right? I need it to be quality. And that's the same thing here. We got to keep pushing our limits, but delivering the quality at the same time.
Yeah, no, and I'm sure you guys have figured out really great quality standards over that many locations too. So you guys are bound to be able to do that with a digital world.
Absolutely.
Well, cool. Well,
leadership and connecting the circle, right? We do something, we got to evaluate it and then improve it and keep that circle going as we go forward.
Yeah, no, that makes total sense.
Yeah.
Well, we mentioned it earlier in your intro about your time being on the medical team at the White House. And I know you probably can't give me anything that's cool with all the probably non-disclosures you have in place, but how was that experience? Anything fun tidbits for us?
Absolutely. That was a life-changing experience working for President Obama and then President Trump and the unbelievable quality medical team that works in the White House every day to protect our leaders, to take care of everyone that's running our government and make sure that they get the best health care. And also when we go overseas, maintaining that health care is a unique challenge of working at the White House. So when you go to whatever country, you have to make sure that our nation's leaders still get that quality healthcare no matter where you are. And so that was really the most challenging and the most beneficial to me and the learning experience to how to deliver that quality care when you go anywhere in the world. And again, that was my introduction into leveraging technology to do these type of things.
Right.
So that it was an incredible experience. It was a great 3.5 years. I traveled the world and got to meet a lot of incredible people and great unit there at the White House that they have.
Yeah, I bet with your military background and that, I'm guessing your OCD on logistics. You probably got that quality in logistics. I mean, you are the guy.
That's right.
I think I'm OCD, but I think after military and doing that, you probably got me beat on the OCD logistics front.
Yep.
Well, it has been such a pleasure to have you on the show. Again, if you guys want to follow, click in the show notes to follow Dr. Barlow or Dr. Bluth. They have both amazing things going on. If you have any questions for either guest, feel free to submit those. We will get you the answers. And always don't forget to subscribe so you get your weekly show delivered in your inbox. Dr. Barlow, it has been such a pleasure. Thank you so much for being on the show today.
Yeah, that was great. Thanks for having me.
Great.
This podcast has come to a close. To hear more from the Executive Innovation Show podcast, subscribe, submit questions, and share the love. Follow us on social. We're everywhere.